Good morning, good afternoon, and welcome everyone to today's webinar, HCPCS Codes, Problem, Progress, and Promise. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You may send in your questions at any time during the presentation. We will collect these and hope to include them in a Q&A session at the end of today's presentation. With that, I'd like to introduce Dr. LaVera Crawley, System Vice President, Pastoral and Spiritual Care with Common Spirit Health. She's a member of Transforming Chaplaincy's Advisory Committee, and she's the lead faculty of Transforming Chaplaincy's Certificate in Spiritual Care Management and Leadership Program. LaVera?
Thank you, Andrew, and good morning or good afternoon, depending on where you're zooming into. Oops, wrong one. That you're video conferencing into. I'm happy to be the moderator here because, like many of you, somewhere around October, as you started hearing this news spreading about this thing called codes, HCPCS codes for chaplaincy, in many of the circles I was in, there was a lot of conversation, a lot of speculation, and equally a lot of confusion. And so I really want to bow to those who are our panelists today, who approached George Fischette and Transforming Chaplaincy and said, we need to get the word out there, we need to be a part of this conversation. And now we have this webinar today that's looking at the Center for Medicare and Medicaid Services Common Coding System Codes, the HCPCS or HCPCS, you'll hear them referred to as HCPCS today, and what that means for us as chaplains. I have the honor of introducing the panelists, and I'm going to introduce them in a little different order than what you see on your screen. This will be the order in which they're going to present. I'll begin with the Reverend George Handzo, who's the Director of Health Services Research and Quality with the Healthcare Chaplaincy Network. George and his organization, the Healthcare Chaplaincy Network, had a front seat from the beginning, and even eventually having a seat at the table that have really moved this process. And so we've asked George to come and talk a little bit about the history of these codes, and I think important for all of us, the advocacy efforts that that we can all learn from, that his organization, the HCN, took to bring these codes to us. George will be followed by Charles Valenti-Hein, or Chuck, who will provide for us a primer on coding and the systems that are used by the CMS to facilitate claims processing. A lot of the misunderstandings about these codes came because a lot of us just don't understand how codes work. And so we're really looking forward to Chuck's presentation. And then at the end, we'll hear from Antonina Olszewski, who's the Vice President of Spiritual Care and Mission Integration at Ascension. Both Chuck and Antonina are from Ascension, and Ascension was also one who had a seat at the table by providing a letter of support for the advocacy efforts that George and the HCNs did. And Antonina is going to explain why these codes are important and the implications for the profession going forward. And so I am really looking forward to our conversation. Just as a reminder, as you ask questions as the speakers are presenting, please put them in the Q&A box, and we will have a Q&A session at the end, which I will moderate. So with that, I want to hand it over to George, and thank you. Tell us a little bit about the history and how we got to where we are.
Good. Well, thank you, LaVera, and thank you to Transforming Chaplaincy for mounting this this webinar. I think this is. I said to the panel before we just opened that we were wondering how many people actually heard about this and thought it was even relevant, and apparently there's a lot of that. So that's heartwarming, I think. I apologize. I'm going to read some of this because I have a lot to say and a little time to do it, and we are serious about having questions at the end and discussion. And like the webinar you may have heard on strategic priorities of the day, this is, we think, only the beginning of this conversation. You will hear that there's a lot we don't know yet, and we're only finding out ourselves. So bear with us. So I'm talk about the why and the how we got to where we are. And I'm going to throw out some acronyms. Don't worry about them. Chuck's going to explain them all when I'm done. You'll have a complete understanding of this. So just bear with me. The why, for decades, Healthcare Chaplaincy Network, HCCN, has tried to work toward a time when every person in the healthcare system gets the spiritual care that they want and need. And not only in presence, not only a chaplain being there, but that quality is high, and they get the right care at the right time, every time, no matter where they are in the healthcare system. I mean, that's really for us the goal. And so it's about access, but also about quality. And as you know, quality has become much more important in recent years in healthcare. I'm sure all of you are aware of that, otherwise you probably wouldn't be on this call. But it is, and it's changing. We're changing, we have to keep up. In years past, when we thought, oh, we didn't need codes, what would we need something like that for? We're not going to do that. We're not going to count. I had a VP some years ago who told his managers, including me, that if they thought they were going to do their job the same 5 years from now as they were doing it now, they weren't going to be here to see it. I mean, that his message is, if you want to continue in this job, you got to change. So it is about change, and one of the paths to this goal is full integration into the healthcare system. That we have for a long time in chaplaincy been kind of separate from the system in many ways, and enjoyed that. And now that's not an option. We have to be integrated. And what we have to do to be one of the things we have to do, there are a number of things. I mean, training is one, credentialing, certification is another, but a main one is data. A colleague of mine, Mike Levy, oncologist, passed me a note on the panel one time that said, it said very simply, he with the best data wins. And that's a little crass, but not much. So it is about getting data, and we've done a lot in the past 20 years to gain evidence and data. And certainly, I need to mention on any call, but certainly on this call, the contributions of George Fischette, and culminating now in transforming chaplaincy, has moved us light years forward, and will continue to do that. I think there's a legacy there that's going to be with us for many years, I hope, to get this data. But we still don't have the amount of data and the data, cross-cutting data, so-called, that other professions have, partly because we don't have access and we don't appear in what CMS, Centers for Medicare and Medicaid, call, appear in the claims-based data. It's a term I'm looking for, sorry. Which simply means that this is the place that data appears when your institution claims payment from CMS or an insurer. And basically right now, because we haven't had codes, we are invisible. And so I, in another capacity on a committee that I serve on for National Quality Forum, CMS was presenting a hospice quality instrument for approval, which needed to have chaplains counted in it, but it didn't, in major part because we don't show up. We're not countable for the purposes of what CMS likes to do. So we were excluded from a count of which was measuring the times that hospice staff visits a patient in the last 3 days of life. We can't be counted in that because we have no way of being counted. And yet, on the other side, we were being denied codes that would allow us to do that. So I think we have come a long way, but we have a long way to go. And it is a chicken and an egg problem. We need data to justify getting the code, and we need the codes to get, to get the data. And how do we break that cycle? Well, I think we have now broken that cycle. That's the step that has now happened. And Chuck is going to explain, as I said, the CMS codes and all of that and all that stuff that still gives me a headache. But it's stuff we have to learn, folks, at this point, especially if you're a director of chaplaincy, if you're running a service, you're going to have to be in conversation about this, and we need to learn it. So what happened with our process? I think we have kind of searched for, as many of us have for a long time, for how to get this data that leads us to more recognition and inclusion and, eventually getting supported financially by the system. When the VA several years ago succeeded in getting codes for the work of their chaplains, that got our attention. And I must say that the VA, Juliana Lesher, who had worked on this and was chief of the VA at the time for chaplains, was more than gracious in sharing with us. And I think this is also about partnership. It's about networking. We would not have even attempted this except for the VA and the wisdom they have encountered. So we did apply. You can only do it once a year in the beginning of the year for these codes. We applied in 2021. We were denied. We had a appeal that you can do. We were denied, even though we had good letters of support. National Hospice and Palliative Care Organization, National Association of Home Care and Hospice, Association of Professional Chaplains all supported us. We were denied, and we thank them for their support, and I think that was all ultimately helpful in the end. We did reapply in 2022. We were again denied. And we kind of gave it one last shot as an appeal. And I think a couple things changed. One was that, as Dr. Crawley mentioned, Ascension weighed in. And they are, as Antonina can tell you, both a care provider and an insurance provider, which is important. And we pushed the example of the catch-22 that I mentioned already. Truly, to my great surprise, Antonina will tell you she had to tell me because I wasn't even bothering to pay attention. We got approved. So now what? Okay, it's like, whoa, now what? Well, I think, first of all, what's important, and you may hear this from several of us, what's important is people have said, when can we start using it? Can we start using this now? The answer is no. And we'll hear a little bit about that because we can't go running off individually and say, well, I'm going to count this, and then we're counting, oranges in Florida and apples in Washington, and we have data that doesn't mean anything. And certainly on this broadcast of research, and people will understand that. So we have to kind of work some things out. What is a spiritual assessment? What is a visit? You may think, well, that's obvious. Well, it's not obvious what a chaplain visit is and should be defined as. So we have to do all of that, and we have to and again, we've had great help from the VA. David Goldstrom at the Atlanta VA now, who worked on the original proposal, has been more than generous with their experience implementing these codes. And these codes will do a lot. They will help us define quality, improve quality, show the quality that chaplains give us data to support requests. It gets us a big step along, but it is one step toward a goal which we're not there yet. We needed this step, we had to have it, but it's not there. They do capture, and this codes, for instance, you'll see don't capture everything that chaplains do. They don't talk about staff ministry, for instance. And you'll say, well, but that's critical. It is. We're just starting, folks. Be patient. took 2 years to get to this point, 3 years, arguably. We need to build, there are 3 kind of steps in quality: structure, process, outcomes. We now have somewhat of a structure with the codes. We need to get a process in place that we can verify works, and then we can start thinking about outcomes when we see what we have. We have to do it I think, in that sense. So the other thing I just want to say before I hand this over to Chuck is this is an all hands on deck exercise. The codes, one of the things we're going to need to do is demonstrate that these codes are used. Chuck will tell you these are officially temporary codes. They can go away. They can be promoted to permanent, but we need to see that they're used around the country, and not just by the common spirits and the Ascensions of the world. So we need every chaplain service. I would say this is a strategic priority to get this into your EMR where it needs to be. You will find some hospitals already have the old versions of the code. Great, but not good enough. And we can help, but you're going to have to do this on the ground. And with that, Chuck.
Thanks, George, and thanks to the HCCN and to the VA for all the truly amazing work that they've done in kind of pulling us to this point. And my journey in this really began several months ago when Ascension saw this as an opportunity to address a very real need we had relating to that whole question of the relationship between the healthcare provider and the insurance company, because Ascension had begun to offer spiritual care as a benefit within some insurance products, specifically Medicare Advantage program, the healthcare marketplace, and our own associate care. So I'm hoping you're seeing that initial screen, and I'm hoping that you're going to see slides progressing. It's helpful, I think, to really kind of get up to a 30,000-foot level and say, so what is medical coding and why is this important to us as chaplains anyway? And I think the most helpful way of thinking about it is that medical coding really is a vehicle by which healthcare providers are able to communicate goods and services that were provided to a patient to the insurance company, the things that they did to address a specific condition or illness. And then in a reciprocal action, insurance companies are able to indicate specifically what it is that they have reimbursed and for what purpose, and frankly also to qualify that this good or service has not been paid for by some other insurer or entity. So, the coding system is a bicycle. And maybe, one of the important talking points is what we are talking about today with these HCPCS codes is one link on the chain of that bicycle. And it's by no means the bicycle. So this is not saying we now are able to bill for chaplaincy services. The bicycle itself, quite frankly, needs a rider in order to get from one place to the other. And in the movement in the use of this system from the medical practice to the insurance company, that rider is almost always a physician or an allied health professional. And in the movement from the insurance company back to the clinic in the form of payment, there are these magical souls called coders who have taken all of this information and processed it. They are akin to actuarials, I think, that they have managed to work with incredibly complex formulas in order to assure that there's a correlation between what is being offered to the patient and what is being reimbursed to the healthcare institution. So some basics, and it's important to do this so that we understand the flow of information that occurs, because that has an impact on what changed in September when these Q codes were approved. At the heart of it all is this document called ICD-10, which is the International Classification of Diseases 10th edition. It is owned and developed by the World Health Organization, and it is the gold standard for diagnosis of disease for the healthcare system worldwide. ICD-1 was first adopted in about 1900. At that point, it was a single volume, and it cataloged all of the diseases really with the purpose of identifying the causes of mortality within countries and creating a common nomenclature so that we would be talking about the same cause of death in England, in Germany, in the United States, in Zimbabwe. This system has grown over the years. Probably one of the most important modifications was ICD-6, in which psychiatric illnesses were first added into the diagnostic scheme. And that had a huge impact by analogy for folks like chaplains who do things like psychologists in terms of offering counseling and care and assessment. The ICD-10 was actually approved in, I think, 1990, and it became the standard, especially because if you remember in the 1990s and 2000s, as HIPAA was approved, ever more careful regulation, and also in the 1980s and 90s, the institution of diagnostic related groups. To be sure that the service that was offered is similarly understood across. So it became the way in which you were able to identify, in terms of ICD-10, the diagnostic criteria that was used for the application of care for a particular patient. It is the why. Once there's a why, then it's important for us to say, what have we done? And the CMS, Center for Medicare and Medicaid Systems, then basically took ICD-10 and with the AMA, codified that as a way that they would be able to identify the specific interventions that occurred in order to address the diagnosis. And that's the current procedural terminology: procedures and services that are provided by allied healthcare providers, ambulatory and outpatient settings, including physicians' offices. These are the codes that physicians use for all of their services in order to communicate to the insurer what it was they did in relation to the why of the ICD-10. Those CPT codes are largely system related. There are some 70,000 CPT codes right now that get to an amazing level of specificity. So that there is a specific code for injury by watercraft and kayaks, a fire in a kayak. I mean, there's a specific code for that. And the various things that are provided in relation to that. But even with that level of specificity, medical insurance claims require oftentimes a greater level of specificity, especially when it comes to the drugs, supplies, equipment, non-physician services that are provided by the physician. So CPT codes are what physicians do to address the original diagnosis. The HCPCS level 2 codes are used by the provider in order to indicate how what they did was accomplished. And within, this gets again to an amazing level of specificity, which is why coders are truly magicians, because HCPCS level 2 codes will include virtually every medication that you can think of. every supply down to a 3.5-inch bandage 5 yards long. But even with that, there are things that are not covered, or there are new modalities of care that evolve. And so CMS has developed Q codes. These are established to identify drugs, biologicals, medical equipment that are not identified by the HCPCS level 2 codes, but for which codes are needed for Medicare in order to process a claim. So we're moving now, not provider to the insurance company, but insurance company to the provider. They need to be able to track what was done in order to get to what George was talking about, the data of whether or not what we're doing works or not. So one more small digression here. Within the ICD-10 code, in the same way that there are Q codes within the HCPCS, within that diagnostic code, there are Z codes. And these are provided for occasions when circumstances other than the disease or the illness or the external cause can be recorded as a diagnosis as a problem. And so there are some circumstances where a problem is present which influences the person's health status, but it's not itself a current illness or injury. And spiritual distress fits exactly in there. And as a matter of fact, you will find specific Z codes. Now, these are, again, within ICD-10, so they're for the diagnosis. Why is this person receiving care? They relate to hospice, they relate to behavioral health, where the behavioral health practitioner determines that there is some spiritual or religious correlate to the disorder that they're diagnosing as a behavioral or mental disorder. So you will find Z codes that refer specifically to spiritual or religious counseling. So we've got the why. What we didn't have was the what or the how. And what we, oh, I'm sorry. What's new here? Again, go back. What we're talking about now are the HCPCS level 2 Q codes, established to identify drugs, biologicals, medical equipment, or in our case, a service. It's not identified by the HCPCS level 2 codes. Those are the CPT codes, but for which codes are needed for medical claims processing. The VA had gone about this process of establishing these 9001 through 9003 codes several years ago because the way that their reimbursement works, they needed to be able to qualify chaplain interventions as a part of the larger care team. At that time, they had, as a matter of fact, requested that it not be strictly reserved to VA chaplains. But CMS said if there is no billing need, if the insurance company doesn't need the code, we're not going to create it. But the VA gave proper argument that there was an insurance need for this. When Ascension joined with HCCN, kind of what we added to the argument was that we did indeed have a claims processing need for reporting chaplain activity. And so the CMS guidance came out in September that broadened these codes so that they were no longer assessment by chaplain services of the VA, but simply assessment by chaplain services. And they break down into 3 categories: assessment, individual counseling, and group counseling. So what we now have is a why. There are instances in which the individual's illness or disease has a correlate which relates to spiritual or religious distress. And we have a how. We've got assessment, counseling individually or counseling in group by chaplain services. What we're lacking is the what, quite frankly. This is an example, and this one works right now. So there's an ICD-10 code for senile dementia with depressive features. And in response to that, that diagnosis, there will likely come a time where that person will qualify for palliative care. And so the physician will order palliative care, and the hospice or palliative care department then will provide a visit. And that what will be a Z code within the CPT, an encounter for palliative care, and qualifying that will be an HCPCS level 2 code, because hospice has already kind of fought this battle. And so there is a specific G code for chaplain services performed by the chaplain in the hospice setting for a 15-minute visit. So that works pretty nicely. It gives us an analogy for the way that this might end up working later as we fully integrate the Q code into our work and service. To get a sense of the messiness of it, take another example. So we have a psychologist in this time who's met with a person diagnosed that they have a delusional disorder. But that, as a matter of fact, it seems to have some religious overtones to it. And so that psychologist has said, I'm going to add a Z code to my original diagnosis, the Y. This person has a delusional disorder, but it has to do with some religious or spiritual problem. What the system gives us now is the ability for the psychologist to provide that diagnosis, but does not at this point provide us with a CPT code, which would say a chaplain provided a half-hour intervention in order to address that spiritual or religious problem. What we do have now is a how, a Q code that could be used in order to say that a chaplain met with this person in order to address that diagnosis of a religious or a spiritual problem. So what we have at this point, if you think back to that original slide, is we've almost built a chain that will connect the healthcare provider with the insurance company, and perhaps more than anything else, some nomenclature, something that means chaplain within this huge system, so that if you see Q009001, 2, or 3 in any documentation, what that is going to refer to specifically is chaplain care, chaplain services. So as George said, there's miles to go, but perhaps the biggest thing in my mind is chaplains have been identified. And I think, Antonina, I hope I haven't made this just entirely muddy, but I'm gonna hand it over to you, and you can make it all clear.
So when you hear how complicated all of that is, please don't assume that I'm going to make it clear. I'm not going to make it clear. But I am going to emphasize a few things that I think do become clearer with the ability to start to track who chaplains are. Going back to something George said in the beginning, chaplains were not seen. So chaplains were providing care. We know that you've been providing care, but there was no way to actually see them when you were reviewing what that care was. What that Q code gives us, as Chuck just mentioned, is the ability to actually see the chaplain in the care process and to see that they provided some type of care. So coding is incredibly complex. I'm so appreciative, as Chuck mentioned, coders are magical and to some extent. But what we're really looking at is, what does that mean for us within the spiritual care department? Why is it important that we begin to track who we are? I'm going to take a step back and just talk for a minute about some studies about the perception of chaplains by healthcare leadership. And I think this will resonate with many of you whether you're a leader or a chaplain, particularly, however, leaders in spiritual care. What a lot of studies show is that executives within the healthcare system really value chaplaincy. And what they value in particular is the chaplain's ability to really frame and focus people on the mission of an organization, right? The core components. And they also value, other things that chaplains bring to the table: support after traumatic events, support towards the end of life, support during times of spiritual distress, although they might not articulate it quite that way. But what the studies also show when you look at healthcare and the way that leadership views chaplaincy is significant variation. So for instance, how are spiritual care programs staffed and integrated into hospitals? Wide variation there. There's been work, particularly within CHA's staffing model, to try to quantify some of that variation, but there's a lot there, studies show. Second, executives have, as I mentioned, viewed chaplains in terms of their quality of care, their responsivity to emergent patient needs, but what they haven't understood very frequently, as these studies show, is the clinical training and background that chaplains have. I would argue that what these codes also help to do is to start to embed that chaplain person, that visibility of chaplain services into the clinical care process, so that now you can actually make that tie to the interventions and assessments that chaplains do to the clinical care that patients are receiving. And that's been a key piece that has been missing, primarily in people's understanding of what chaplains do. Finally, what those studies show when thinking about healthcare leadership's view of chaplaincy is that very few departments have relied in the past on empirical data when making decisions about chaplain staffing in particular. And the reason why is because we haven't had a lot of data about spiritual care. So very frequently, they have defaulted when thinking about chaplains or spiritual care departments to budgetary status quos. And I'm sure all of you have understood that when budgets get tight or budgets vary or budgets change, people look at chaplains and think, I don't know, do we need that in the budget? How do we need that in the budget? Do we have any data around chaplaincy? Not as much as we needed. Healthcare is an organization and industry that's driven primarily by data. And going back to another thing that George brought up that I am firmly in agreement with is we have been in a chicken and an egg situation. People have said data wins, right? Data is what shows your value. And yet we have not had the ability to gather a lot of data around spiritual care. We have, and thank you again to George Fischette, I have to lift that up, but we have started to gain a lot of research about the value of spiritual care. And I hold up in particular an article that came out this past July in JAMA called Spirituality and Health and Serious Illness, that really starts to speak to the need for better spiritual care intervention into the treatment of people who are chronically ill or seriously ill. So we're starting to get that research that's lifting up the importance of spiritual care in the care process, in the clinical care process. But what we had still missed was that ability to demonstrate that we had provided that care and where, and to count it. So this Q code is going to allow us to start to track those interventions and create that data set that shows a correlation between spiritual care and outcomes and impact in clinical care treatment. We're not quite there yet, but this is the start, right? And I would argue again, within healthcare in particular, if you don't have the data to show that your intervention is impactful, it becomes very difficult to make an argument that you have value. Now, one of the things I've heard frequently in spiritual care is, well, spirituality is not quantifiable. It is present, it reveres the human person, it's essential, but it's not really quantifiable. And I would argue spirituality is in many ways not quantifiable and intrinsic to the human person. But the provision of spiritual care, in other words, what chaplains do, actually is quantifiable. We can start to track those interventions. We can start to count the ways and times that chaplains intervene or contribute to the clinical care process. And that's what these codes will do. So why do I think this is so important? Why am I so excited about this as a leader? Because these codes will really allow us to demonstrate the needed, I say it again, intervention of spiritual care. But going back to something said earlier, if we don't use these codes, if as chaplains we don't actually track our work, then we're not demonstrating the need. And in fact, if we don't use the codes, not using them demonstrates a lack of need of spiritual care. So I want to hold up something George said, and that is we need to get these embedded in our EHRs. And as spiritual care providers, you need to start using these codes when you're providing services. The other thing I think that these codes do, and I'm excited about it, but I also hear that there's some trepidation in our space, is it starts to really hold us accountable to a level of clinical care that really does provide the type of intervention that we say that we can provide. In other words, spiritual care has value, and that without adding spiritual care to clinical care, we are truly not living into best practice healthcare. And in fact, referring to that JAMA article again from this past summer, Spirituality and Health and Serious Illness, and I'm repeating it because I think if you haven't read it, everybody needs to go out and look up that article. What that article basically lifts up is it's going to be difficult to be providing best practice healthcare, particularly when treating patients with serious illness, if you don't include spiritual care. So we are being called into this space of need. We are being called to say, yes, spiritual care is important. Yes, we need to be including spiritual care partners, chaplains, as part of the clinical care process. And yes, we need to be documenting that to show the impact of our work, the importance of these spiritual care interventions. So I want to say out loud one thing that if I've been asked one question since these codes came into existence, I've been asked it 100 times, and that is, can these codes be used for billing? And the answer right now is an unqualified no, they cannot. However, as Chuck so nicely articulated, it's a component of the chain that will start to build that bicycle that one day might lead us into a different understanding of how spiritual care contributes to health and allow for us to start to create some revenue streams that include spiritual care. But first and foremost, this gives us that piece we've really been missing, and that is that piece that says, here we are, now you can see us, here is where we provided care, and here was the impact of that care. Granted, that's a correlative impact, but still, here's a patient who had a serious illness, had lots of interventions done, including spiritual care, and this is how well they did. And conversely, here's a patient in the same situation who didn't have a spiritual care intervention. And we can start to compare what that value, that intrinsic value of our spiritual care interventions really is. Finally, George referred to something about really where we need to get in spiritual care, right? Our structures and then our processes to lead to our outcomes. And we are finally really creating that structure. And I would say, yes, we've had structures within spiritual care. People just aren't, out there doing whatever they want, right? We do have structures, but we haven't had a structure that was really recognized nationally by both the government, like CMS, and insurance companies. Where we need to go from here, though, is that ability to actually create some processes that can be replicated across systems and across the country in order to start to say, here's the data that led to these outcomes. And we agree within spiritual care that if you do this intervention with this type of patient, with this type of diagnosis, spiritual care is a benefit and will create an outcome that is different than without spiritual care. I would add beneficial, but actually we're really tracking what that impact and that difference is. So what excites me about this is that ability to say, here we are, here's something that we do, here's how we can start to count it and track it. And eventually to work with our research partners, our data partners, people like Transforming Chaplaincy, to say, now let's start to do research on how we can actually quantify these interventions. And oh, by the way, we can now pull that data easily by pulling that data based on a Q code for spiritual care. So I hope that helps to tie a little bit of the value of this. I know some of this was a little bit complex. I'll be honest, I have been on 20 calls at least to have the coding explained to me and where the Q codes fell into that system and process and what it meant. So my thanks again to Chuck for working through this systematically over the past 3 months. And again, thanks to George and HCN for bringing this application to CMS again, so that we could start to create this, I would say, future possibility for the value of spiritual care in a way that others understand, knowing that within spiritual care, we have always understood the value, but we now need to be able to prove that using the language that the other healthcare clinicians use, which is very frequently data. So I want to leave time for questions. I hope there are some. I'm sure that this is a complex topic, but basically I'm going to lift up one more time because it cannot be oversold. Once these codes are in place in our health records, we need to be diligent about using them. Thanks, LaVera. Let me turn it over to you.
There's a lot of interest and questions here, and I'm going to not read them individually, but sort of pick out the themes. And I'll pick up first with the baton you just handed us in terms of sort of the practical next steps, questions about process. So there are questions about how do we get these codes into our electronic records? There are questions about, well, who would actually be doing that? Who's putting these processes together? Not only locally, so who would I go to in my organization to start saying these codes are now coming available? How do we use them? How do we put them in our records? But also then who is sort of shepherding this nationally, because we do want to have some consistency across the board. And then the third aspect of that is, well, what about the private sector? Those who maybe not be in hospital settings or in health systems. So what are the next steps for these processes?
I'll be gracious to let you start, Antonina.
So I don't know that I'm the best person to start, but I'm going to say one of the things about coding that I'm learning is that for most systems, that CPS codes and ICD-10 codes are automatically updated, generally on an annual basis within systems. So there's an element of these codes that now that they're becoming available in the next iteration of updates into coding processes, whatever that is for your organization, those should be included. The other question is, how do they get built into your EMR? I could start there. Chuck, I know you've done a lot of work in that. Do you want to take that one, or do you want me to start and have you correct? I'm fine either way.
Oh, go ahead.
So one of the ways that you really need to start to look at where these codes belong is to work with your system's individual coders and billers. So within Ascension, we've been having multiple meetings with 3 primary stakeholders: our IT folks, our billing folks and our coding folks to start to ask, where can we embed these Q codes, and how do we start to track how they're being used and who can use them? Ascension is a very large, multifaceted organization, and we have talked a lot about doing this in a small subset of our footprint. So one market in one EHR, for instance, to work out some quirks with it. So my initial thought for all of you would be, you need to gather those stakeholders within your organization and start to have conversations about how they can embed these and what that looks like, because I am not the expert in this space, they are. So I go to them and basically put forward what they are, and they tell me how best to start to integrate them into our system.
Yeah, let me jump in on the there was a piece about who's going to shepherd this nationally. I don't know that I don't know about shepherding nationally. We'll have to see how much uniformity there is, and it's still not clear to me what training policy is needed. I mean, if we're finding these codes everywhere and it's just going to change next month and we'll be fine, then that's one thing. I think what we at Healthcare Chaplaincy are looking at is, how can we start to do what this webinar is doing in a more consistent way, which is gather and disseminate best practice, and to say, here's, if Ascension would be willing to write something and say, here's what we've done and here's how it's worked. We've talked to other centers who would do that. That we would see as a role that we can fulfill to kind of keep this ball going, and say what's needed, what training, because we know chaplains don't know about this stuff. I can't do it myself. I couldn't tell you how to do it. And your place is going to be different than the next place down the street. So I think you need to start, and then let's see where we run into barriers, and let's talk about them. Let's get them. Maybe we need another webinar, George Fichette, about that, or 2 or 3, and or maybe we need a manual or best practice paper. I don't know, but that's kind of where our thought process is starting to go, because we don't have patience, but we can do that.
Yeah, the thing I would add is, I think what we're looking at is that these codes provide us with an opportunity for innovation. Innovation always works better if you have more partners around the table. If I have a bunch of surgeons around the table, they're going to figure out how to do surgery. If I've got a bunch of chaplains, they're going to figure out how to pray. But if I've got a doctor and a chaplain and a social worker around the table, I may be able to actually come up with something that could work. So innovation, which would include getting the people who know how these things work around talking to you. But the chaplain's role, or the chaplain leader role, is to say, there's now this thing. You understand it better than I do, but I think it might be helpful for us. Can we talk about it? And then I think innovation always works best by iteration. We will not get this the first time we try. But the more we try it and share our results with each other, the VA is absolutely essential, because they were the first iteration, and there's plenty to learn there, and they have been so gracious in sharing their experience and wanting others to come alongside. Ascension has begun a new iteration, but we need to be working together with all this information.
Yeah.
There's one other question that came in. I think you've answered it, but I just want to highlight that this idea of really needing some templates for assessments. But I hear you reframing that, both George and Chuck, as sort of best practices and that sort of thing. But there's also a lot of questions about, and Antonina, you clarified this is not a billing code. However, there's been a lot of intimation about insurance needing it, and could it possibly lead to that? So there are a series of questions that are coming in around that, particularly and maybe we would just say we'll wait and see because they're not billable yet. But let's just imagine that they're leading into that direction. So what happens? What's the implication for using these codes as billing for a patient that actually didn't want spiritual care, but it was there in the first place? And then, for example, well, then if an insurer denies those, will they pass that cost on to the patients? So there's a lot of, fear about what are the downsides of having this.
So I think that fear is a little bit anticipatory at this time because we're not to a point yet where we can bill. And that conversation about iterations and innovation, I think is going to lead us to opportunities for the way that we create best practices to integrate spiritual care. Will there be a potential misstep down the road about the way that's used? Perhaps, but that's very far down the road, I think. One of the things that I would highlight and lift truly is until we have this ability to create this understanding of the value and best practice of clinical care that includes spiritual care, we're still always going to be seen as, I think, George, you said, other than or outside of kind of the main process of clinical care. And I think the thing that I hope all of us take away from this is we really need to be considering spiritual care as fully integrated into clinical care and essential to true clinical care. And these codes are just a step in helping us be able to start to track that so that we can prove that.
Yeah, and I would just add quickly, my sense is that we've talked about this as if we're going to be in a fee-for-service economy going forward, and my guess is we're not mainly. We're going to be in a bundled payment. But even there, if Ascension's going to kind of make up how they're going to bill or what they're going to need from insurance company X to take care of kidney dialysis patients, we want chaplaincy involved. That would involve saying how much spiritual distress is there in the kidney dialysis population, what chaplain interventions are used to satisfy it, and then we can some cost, and then we can posit a good figure for how much money chaplains need to include in there. Right now, we don't know any of those numbers to put into that equation, but we can find them now.
We're just about at time, but there were just a couple of other questions about just clarification that this isn't just hospital-based coding. Could this also be in long-term care? Can this be in trauma? Can this be in other areas as well?
Yes.
So just to be clear, yes, these codes are used universally in any type of healthcare delivery model, regardless of acute care setting, outpatient setting, home care setting, et cetera. So yes.
If there are listeners who are in a Canadian context, there's an analogy to it, but it would not, we're talking probably about healthcare delivery in the United States with the Q codes.
They want us to share a lot of resources, including the slides, but just a reminder that if you did register for this, you will have access to the presentation again, a recording of it. We will include information about the JAMA article that Antonina has begged us to make sure we not only read it, but use it. And others want to know, again, the video and the slides, information about that. So we are now just about at the top of the hour. I just want to bow to each of the three of you, and again, to Transforming Chaplaincy and George Fischette. This was an excellent primer on first steps. And we are certainly going to adhere to some of the suggestions here, that this just be the first of many ways that we are communicating and sharing our questions and information about this as it all unfolds. So thank you, Antonina, Chuck, and George for a really wonderful presentation today. Thank you.
Thank you so much, LaVera, and thank you, T3, for inviting us to this space.
Thanks to Andrew for all of his work.
Thank you so much.
Hey.